There were 33 patients in this trial, and the point of it was to really understand if the NK cells added any benefit to standard transplants. So with the same melphalan 200 conditioning regimen, we again gave NK cells 2 days later in the context of a very low dose lenalidomide. Now, something interesting about this phase 2 trial is that the patients that were on it, not surprisingly, were a little higher risk. A third of them had ISS stage 3 disease, and a third had adverse cytogenetics or FISH, and a third had a history of progression or relapse. And actually, all in total, I believe more than or around 3/4 of the patients had some adverse prognostic factor, and so this was a higher risk group than you would expect going into the trial, going into a transplant. And we were able to see that the cells were well tolerated. We did not have any graft versus host disease. We did not have any cytokine release syndrome. We did not have any neurotoxicity. There was one patient who had had graft failure, but we realized this was because the actual graft that she had gotten for her stem cells was actually not ideally cultured or not ideal in quality, and so she was rescued with a separate graft of her own cells. But other than that, we really had no safety issues. And the responses at day 100, the best responses, and we were really looking for VGPR or better. We had 79% of patients get VGPR or better, which is really something that was good in this patient population. It was interesting to see that 40% had stringent or near stringent, stringent or CR, a stringent CR, and also 64%, I believe, had near CR or CR. We looked at MRD at a 10 to the minus 5 sensitivity, and were able to find that at day 100, 61% of those patients were able to have MRD negativity, which is good for this patient population. So far, median progression-free survival hasn't been reached. 3 of the patients have passed away, so that's about a 90% survival rate so far, but the median follow-up time is about 2 years, so we have to wait longer. The estimated 3-year PFS is about 52%, but we have to wait longer to better understand the durability of this. Again, that's not the same as you would have in a standard risk population with transplant and maintenance, but this is a higher risk group. And the purpose of this long train from 10 years ago to now was really to understand, can we use NK cells as adoptive therapy? And I know the answer is that we can. Now, what are we going to do with that? We could potentially manipulate the NK cells more to be longer lasting and have more persistence, and that's one of the things that we're looking at, because we do know we were able to detect donor-derived NK cells in over 2/3 of the patients, probably more if we actually had a more sensitive assay. So in the future, I think that we'll probably be able to engineer NK cells maybe to persist longer, and possibly one of the things being worked at MD Anderson and other places is engineering the NK cells to be chimeric antigen receptor NK cells, so specific for myeloma specific proteins, and I look forward to that data.